Welcome back to the Deep Dive. Today we are strapping in for something that sounds, kind of routine on the surface, but is actually physiological roller coaster.
It is.
We are heading into the operating theater for a total knee replacement, or TKR. Now, to the uninitiated, this is just carpentry, right?
Right.
But for the anesthetist, it's a minefield.
It's so good to be here, and you were absolutely right. Routine is probably the most dangerous word in anesthesia. It breeds complacency. And in a TKR, complacency is what causes you to miss those really subtle signs of a disaster that's just unfolding.
Exactly. I think a lot of people, maybe even some residents early in their training, they look at a TKR list and think, okay, spinal, pop them in, have a coffee, wake them up.
Yeah, easy day.
But the sources we have today, I mean, we're looking at standard texts like Miller, Morgan, and these really specific exam guides for the Gujarat University MD exams. They paint a very, very different picture.
They certainly do. I mean, if you treat a TKR as a simple case, you are you're missing the landmines. And for our listeners who are getting ready for their exams, missing those landmines means missing the pass mark. It's that simple.
And that is our mission today, isn't it? We're going to role play this. You are the senior faculty. You're the examiner who has seen it all, marks the papers. I'm the candidate who really needs to pass this exam.
Okay.
We're going to break down bone cementing, tourniquet physiology, and the anesthetic management that you need to survive them both.
That is the mindset. We aren't just chatting here. We are preparing you for the Viva.
Yeah.
We are looking for those high-yield points, those Viva traps that examiners just love to set.
Right.
And we're going to talk about the structure you need to write down to get a full 20 marks on a theory question.
I love it. Okay, so roadmap. We have 4 parts. Part A is bone cementing, specifically the implantation syndrome, which sounds terrifying. Part B, the tourniquet. What happens when it goes up and, more importantly, when it comes down. Part C is the actual anesthetic management, the how-to. And then Part D, exam integration, how we package all this knowledge up to get full marks.
That covers the entire spectrum, so let's scrub in.
Let's do it. Part A, bone cementing. To the lay person or, even a junior medical student, this sounds like we're just gluing a joint back together.
Yeah.
But for the exam, how do we define this stuff?
Okay, this is the very first place people lose marks. You have to define the substance properly. It's polymethyl methacrylate, or PMMA.
PMMA. Got it.
And here is the key concept for your short note, for your Viva. It is not glue.
It's not.
Yeah.
I think most people, myself included,
Yeah.
kind of visualize it as a super adhesive, like super glue for bones.
That's a really common misconception. And if you say adhesive or glue in a Viva, a good examiner will stop you right there.
Okay.
It doesn't have chemical adhesive properties. It acts as a grout, or maybe better word is a space filler. It relies on mechanical interlocking.
What do you mean by that, interlocking?
It gets pressed into all the tiny spaces of the cancellous bone. It interdigitates.
Yeah.
And that creates a super tight fit so the prosthesis can't move. It's all about filling the void, not sticking the surfaces together.
Okay. Space filler, not glue. That's a key takeaway already. And there's a chemical reaction happening here that we need to know about, right? It's not just mixing Play-Doh.
Oh, absolutely. You mix a powder, that's the polymer, with a liquid, which is the monomer. This kicks off a polymerization reaction. The key word you absolutely need to write down is exothermic.
Exothermic.
Heat. It generates significant heat. This reaction causes the cement to harden and, crucially, to expand against the bone and the prosthetic components.
And that expansion, that's where the trouble begins.
That's precisely it. This expansion creates incredibly high intramedullary pressure, and that pressure is the engine behind one of the most feared complications in all of orthopedic anesthesia, bone cement implantation syndrome.
BCIS.
BCIS. This is a major exam topic. I feel like this comes up constantly in study guides. It is absolutely essential. You will be asked to define it. So BCIS is a syndrome characterized by hypoxia, hypotension, and sometimes cardiac arrhythmias, all occurring around the time of bone cementation and prosthesis insertion.
We're not just talking about a little dip in blood pressure, are we?
No, not at all. The sources, they really emphasize that while subclinical events are super common, I mean, if you put a transesophageal echo, a T-probe, down the throat of almost any TKR patient, you will see showers of debris.
Wow.
But full-blown BCIS, that can be fatal. It turns a stable patient into a cardiac arrest situation in seconds. Intraoperative mortality is a very real risk here.
Let's talk about the timing. When exactly does the examiner want me to be most vigilant? Is it just during the surgery? That seems too vague.
It is too vague. You need to be specific. There are very clear danger zones. Femoral reaming, cement application, the actual insertion of the prosthesis, and finally joint reduction. If your patient crashes during any of those moments, you have to assume it's BCIS until you can prove otherwise. The examiner wants to know that you are watching that monitor like a hawk during these specific steps.
Okay, let's unpack the pathophysiology. This is usually the meat of a 20-mark question. What is actually killing the patient here?
So there are two main theories you need to be able to present. The first, and this is generally considered the dominant theory, is the mechanical or embolic model.
Which makes sense if we're talking about high pressure in the bone.
Correct. You have this intramedullary pressure just shooting up, sometimes over 500 millimere Hg. It's huge. And this forces what I call a debris cocktail into the venous channels.
Debris cocktail. That sounds horrific.
It's exactly what it sounds like. It represents the contents of that medullary canal. It's a mix of fat, bone marrow, tiny cement particles, and even air. This sludge gets pushed into the femoral vein, travels up to the right atrium, into the right ventricle, and then it just slams into the pulmonary artery.
So it's basically a massive pulmonary embolism.
Yes, but you need to be more specific with the downstream effects. It causes a massive sudden increase in pulmonary vascular resistance, or PVR. This leads to acute right ventricular failure.
Why does the RV fail so quickly?
The RV is a thin-walled chamber. It's designed to be a volume pump, not a pressure pump. It absolutely cannot handle that sudden wall of resistance. It fails, and it fails rapidly.
Okay.
When it fails, the RV dilates. And because the heart is enclosed in this fixed pericardial sac, that dilated RV pushes the interventricular septum over to the left.
The interventricular septum shifts. That sounds like a really critical concept.
It is the mechanism of death. You need to know this. That shift physically squashes the left ventricle, so left ventricular or LV filling just plummets.
And if the LV can't fill?
It can't pump. Cardiac output drops to nothing, you get profound systemic hypotension, and then cardiac arrest. This whole cascade is the spiral of death for BCIS.
Wow. That's the mechanical side. What was the second theory?
The second one is the biochemical or monomer model. The idea here is that the circulating methyl methacrylate monomer itself, that liquid part of the cement that gets absorbed, causes direct vasodilation and myocardial depression.
So the chemical itself is actually toxic to the system.
That's the theory. It's also thought to trigger this huge release of inflammatory mediators, things like histamine, complement activation, and even endogenous cannabinoids like anandamide. All of these cause profound vasodilation.
So in the worst case scenario, you have a mechanical blockage in the lungs stopping blood flow forward, and D, your systemic vessels are dilating chemically, dropping your pressure from the other end.
Exactly. It is a double hit. For the exam, the safe phrase, the one you should write down, is a multimodal pathophysiology combining mechanical obstruction and mediator-induced vasodilation. That covers all your bases.
Smart. Okay. Now, clinically, what am I seeing on my monitor? What am I looking for?
You were looking for the classic triad: hypoxia, hypotension, and loss of consciousness.
Loss of consciousness. But what if they're under general anesthesia?
Good question. Obviously, under GA, you won't see them pass out. Under GA, the very first sign is often a sudden, sharp drop in end-tidal CO2.
Ah, right. Because cardiac output has just crashed, so there's no CO2 being returned to the lungs to be exhaled.
Exactly that. A sudden drop in EtCO2 during cementing is a terrifying sign. It almost always precedes the drop in oxygen saturation and the profound hypotension.
And if the patient's awake, under a spinal?
That's where you might get a more classic presentation. They might suddenly complain of dyspnea, of chest tightness, or they might just become altered, confused, and unresponsive.
So who is most at risk? When I'm doing my pre-op assessment, who am I really worried about?
Think of it as the fragile vessel, your ASA grade 3 or 4 patients, people with significant pre-existing cardiopulmonary disease and especially pre-existing pulmonary hypertension.
Right, because their RV is already under strain.
Precisely. Their right ventricle is already struggling. It has no reserve. It absolutely cannot handle that sudden increase in resistance from the emboli.
And what about the bones themselves? Does that matter?
Oh, hugely. Osteoporosis is a major risk factor. Poor quality bone requires more cement and more pressure to get a good fix. Also, patients with pathological fractures or metastatic bone disease are at very high risk.
Okay, so I've identified my high-risk patient. I'm in the theater.
Yeah.
The surgeon picks up the cement gun. What is my management plan? This is the manage this case part of the exam.
Right. Management starts with prevention. You need to be communicating with your surgeon. They can do things to help.
Like what?
They can use high-pressure lavage to wash out as much of that debris as possible before cementing. They can also use a vented femoral shaft basically drilling a little hole to let the pressure escape rather than forcing everything into the veins.
And from my side, the anesthesia side.
Your main job in prevention is to ensure the patient is normovolemic. A dry, hypovolemic patient will crash much faster and harder. But here's the algorithm for the crisis itself. Step 1 is anticipation.
Okay.
Increase your FiO2 to 100% before the cement goes in.
Don't wait for the sats to drop.
Never. You are buying time. Step 2, hemodynamics. You need aggressive fluid resuscitation to maintain preload to that struggling right ventricle.
So fluid bolus.
Crystalloid, colloid, whatever you have. Step 3, pharmacotherapy. You need to restore that systemic vascular resistance, the SVR, because of the vasodilation we talked about.
So vasopressors.
Yes. Alpha agonists like phenylephrine or noradrenaline are your first line to tighten the vessels. But if you suspect the right ventricle itself is failing, you might need inotropes like adrenaline or milrinone to help it pump.
And what's the last step?
The most important one, communication. Tell the surgeon to stop, or at least to reduce the intramedullary pressure immediately. If the prosthesis isn't all the way in, they might need to back off for a moment.
That's a great algorithm.
Yeah.
Okay, that covers the cement. Now let's move to Part B, tourniquet physiology. This seems, I don't know, safer, less chemical, but you still called it a minefield.
It's a pure physiological stress test. We use tourniquets to create a bloodless field. Cement bonds better to dry bone, and it helps the surgeon with dissection. But we have very strict limits. The 2-hour rule is the golden standard.
2 hours max.
Ideally, you want it down in under 100 minutes to minimize the risk of muscle ischemia and, importantly, nerve damage.
Okay, let's talk about inflation. The surgeon says, tourniquet going up. What happens to my patient physiologically?
You are literally squeezing all the blood out of a large limb and forcing it back into the central circulation. It's like giving an autotransfusion of about 500 mL.
So preload goes up.
Preload goes up, and at the same time, you are clamping off a huge vascular bed.
So afterload goes up too.
Correct. So systemic vascular resistance, SVR, jumps up. You've got increased preload plus increased afterload. The result is transient hypertension. You will see the BP spike on your monitor.
And that could be dangerous if the patient has a bad heart.
That's the key. If they have poor left ventricular compliance, that sudden volume and pressure load can push them into acute heart failure. But then, after a minute or two, things seem to settle down, or so it seems.
The silent phase, you called it.
Right. While the BP stabilizes, the leg distal to the cuff is ischemic. It's dying. It switches to anaerobic metabolism after about 8 minutes. Lactate is building up. CO2 is building up. Potassium is leaking out of the cells. It is a toxic soup just brewing behind that cuff.
And then comes the end of the surgery. The surgeon says, tourniquet down.
This is the deflation phase, and for your exam, this is absolutely essential to understand. This is the washout effect.
What happens?
That dam breaks, all of that metabolic soup, the lactate, the CO2, the potassium, it all floods into the systemic circulation at once.
Okay.
And at the same exact moment, that vascular bed in the leg, which is now maximally dilated from the ischemia, opens up.
So all the blood just rushes back into the leg?
Exactly. So you get a sudden massive drop in SVR and a simultaneous drop in preload as the central volume redistributes. The result is profound hypotension.
It's the complete opposite of inflation.
Precisely. And on top of the low BP, the blood returning from the leg is acidic and it's cold. This directly depresses the myocardium. And you'll see a sudden sharp rise in your end-tidal CO2.
Wait, let's pause right there. That's huge. In BCIS, you said the ETCO2 drops. In tourniquet deflation, it rises.
Boom. That is the exam trap. That's the question they will ask you to differentiate. If the patient collapses and the ETCO2 goes down, you have to think embolus or primary cardiac output failure, like BCIS.
Right.
If the patient gets hypotensive but the ETCO2 goes up, you should be thinking metabolic washout from the tourniquet deflation.
That is such a crucial distinction. What about the potassium?
You'll see a transient hyperkalemia. Now, usually a healthy patient buckers it pretty well, but in someone with renal failure, it could be enough to trigger arrhythmias.
Okay, before we leave the tourniquet, we have to talk about tourniquet pain. I've seen this. The spinal is working perfectly. The patient can't move their legs at all. But about 45 minutes in, they're getting agitated and they're pointing at their thigh.
Yes, this is an exam favorite. The mechanism is all about the different types of nerve fibers. The local anesthetic from the spinal blocks, the myelinated A delta fibers, those carry shark pain quite easily.
Okay.
But the unmyelinated C fibers, which carry that dull, aching, burning pain, are much harder to block and they tend to recover faster.
So the C fibers start firing even when the skeletal is still working for everything else.
That's it. It usually starts 45 to 60 minutes after inflation, and it presents as a dull, aching pain, or more commonly under GA as hypertension. We call it tourniquet hypertension. The patient's BP just starts to climb for no apparent reason.
And just giving more fentanyl doesn't always seem to fix it.
It's notoriously resistant to conventional opioid analgesics. You can try deepening the anesthetic or the sedation, maybe use adjuvants like ketamine, but often the only real cure is asking the surgeon to deflate the cuff.
And quickly, what about other complications, aside from the pain?
Well, the big one is nerve injury. That's a combination of mechanical compression and ischemia, which leads to neuropraxia. This is why we have that 2-hour time limit. Then there's muscle injury. Rhabdomyolysis can occur if the tourniquet is up for too long. And of course, thromboembolism. The stasis of blood can promote clot formation.
Okay, that makes sense. Let's move to part C, the actual anesthesia for TKR. We've done the deep dive on the physiology. Now we have to actually manage the patient through all this. Starting with the pre-op assessment. What's the focus?
It is a geriatric game most of the time. You are assessing functional reserve. The best question is often the simplest. Can you climb a flight of stairs without getting breathless? You're specifically looking for ischemic heart disease because that tourniquet hypertension is a real stress test for the heart. And you're looking for any signs of poor RV function because of that BCIS risk we talked about.
And medications.
Anticoagulants are key. TKR has a high risk of DVT. So many of these patients are on blood thinners. You need to know exactly when they stop them to be able to safely perform a neuraxial block, like a spinal.
That brings us to the big debate, regional versus general anesthesia. What is the gold standard answer for the exam?
For TKR, regional anesthesia, and specifically neuraxial, like a spinal or an epidural, is considered the gold standard.
And why is that? Why not just put them to sleep and control the airway?
There are several reasons that examiners absolutely love to hear. First, DVT prophylaxis. The sympathectomy from the spinal actually increases blood flow to the legs, which reduces stasis and clot risk.
Okay, that's a good point.
Second, it blunts the surgical stress response much better than GA. Third, and this is very important, it keeps the patient awake.
Why is keeping them awake so important here?
So we can monitor their mental status in real time. If a patient under a spinal suddenly gets confused or starts complaining of chest pain during cementing, that is your early warning system for BCIS. Under GA, you miss that completely.
That makes perfect sense. So when would you ever choose general anesthesia?
Of course there are times. If the patient flat out refuses a needle in their back, or if they have severe coagulopathy or maybe severe aortic stenosis where you just can't tolerate the sympathectomy of a spinal, then GA is the way to go.
What are the drawbacks to mention?
You have to mention the drawbacks. Higher DVT risk, more postoperative nausea and vomiting or PONV, and generally poorer initial pain control right after they wake up.
Let's talk about that pain control. TKR is famously painful.
It's one of the most painful orthopedic surgeries there is. You need a robust plan from the start. We always use a multimodal approach.
So paracetamol, NSAIDs.
Paracetamol, NSAIDs if their kidneys are okay, and a baseline of opioids. But the nerve blocks are the real game changers.
Which blocks are we talking about?
So, historically, we used the femoral nerve block. It provides fantastic analgesia for the knee joint itself. But there is a pretty big catch.
WADs. It weakens the quadriceps muscle.
Exactly. It completely knocks out the quadriceps muscle. The patient can't extend their knee properly. This significantly delays mobilization and increases the risk of them falling when they first try to walk.
And early mobilization is key for recovery after a knee replacement. So what's the modern answer?
The adductor canal block. This is a very high-yield topic for modern exams. It targets the sensory nerves, like the saphenous nerve in the distal thigh, but it spares the motor fibers to the quadriceps.
So they get pain relief, but they can still walk.
That's the beauty of it. The patient has good pain relief, but can still actively participate in physiotherapy on day one.
That's a great detail to drop in an answer. Okay, let's go to Part G, exam integration. We need to synthesize all of this.
Right. So if you get a question asking you to compare cemented versus uncemented processes, you structure it by risk and benefit. Cemented. Benefit is immediate fixation, but the risk is BCIS. Uncemented. No BCIS risk. But the benefit of slower integration depends on good bone quality, and the surgeon has to be more precise with the fit.
And let's revisit that Viva trap about the patient collapsing.
Yes. The examiner asks you, your patient collapses 5 minutes after the tourniquet goes down. Is it BCIS?
And I confidently say.
You confidently say, unlikely. You explain that BCIS happens during cement insertion. A collapse at deflation is much more likely to be due to hypovolemia, reperfusion injury, or that washout of acidosis. Timing is your diagnostic tool.
Perfect. And if they ask, how do you treat tourniquet hypertension?
Do not just say, I'll give antihypertensives. The answer is, I will treat the cause. And the cause is pain. So deep in the anesthesia or treat the pain first. Treating the number on the monitor without treating the patient is a classic junior mistake.
And for the written exam, that big 20-mark question, how do I structure the answer for discuss anesthesia for TKR?
You have to use headings. Examiners span for headings. They make it easy to award marks. Start with introduction and definition. Then pathophysiology. And this is where you can draw that simple BCIS flowchart. High pressure leads to emboli, leads to lung, leads to RV failure.
Okay.
Then clinical features, then pre-op assessment, then intra-op management. And you can even break that down into induction, maintenance, and crisis management. And you must finish with post-op analgesia. If you follow that flow, you will pick up marks in every single section.
That is incredibly helpful. Before we wrap up, you mentioned a provocative thought for the end, something to make us think beyond the textbook.
Yeah, so we talk a lot about BCIS and the catastrophic outcome of cardiac arrest, but I want you to consider the silent emboli. We know from those T studies that almost every cemented hip or knee sends showers of this debris to the lungs, and potentially to the brain if there's a PFO, a patent foramen ovale.
A hole in the heart.
A very common one. We often see elderly patients decline cognitively after major surgery. We tend to blame the anesthesia. But is it really the drugs we use, or is it the fact that we just showered their brain with thousands of micro-emboli from their own bone marrow?
That is a very sobering thought. It really highlights why the gentleness of the surgery and our management of those pressures matters so much.
Exactly. It's not just plumbing and carpentry. It's all physiology.
Well, there you have it. From the chemistry of the cement to the pressure of the tourniquet and the art of keeping the patient safe through it all.
My advice is to visualize these swings. When you are in your next TKR case, watch the monitor during cementing. Watch that ETCO2 during deflation. See the physiology happen in real time. It'll stick with you.
And good luck to everyone preparing for the Gujarat University exams or any exams. You have got this. Check out the show notes for a recap of some of the key points.
And remember, always maintain a high index of suspicion.
Thanks for listening to The Deep Dive. We'll catch you on the next one.
Goodbye.
See ya.